Good evening, everyone, and I think we need to thank Dr. Vamshi for stepping in at the last moment. Thanks, Vamshi. So, with that, I think we have a 45-minute panel to start with. We'll try and get it to 30, I'm assuming. And now it's 25 minutes. Great. Okay, so I'll discuss two case-based scenarios, predominantly GB, because that's our problem. I'll start with Shekhar Patel, sir. These are 4 general questions. What proportions of patients do you see with GB as compared to non-GB, cholangiocarcinomas, etc.? And how many of them are resectable in your practice? And do you treat non-metastatic differently from locally advanced? I'll take 2 opinions on that and start with you, sir.
We have got, I think, if you take the biliary tract cancer as a whole, and if you divide between the gallbladder versus the biliary tract itself, maybe around 20-25% are gallbladder cancers are there, out of which.
Okay. Yeah. So 75% are not gallbladder?
No, sir. Maybe other extrahepatic, periampullary, intrahepatic.
So 25% gallbladder.
Maybe 25, more than 25, 30
so,
35 I should say.
So as we all understand that the gallbladder is more common in the northern part of the country, and coming from that part of the country, I will say the reverse way, that it's around 80% of the patients are frankly the gallbladder. Yeah. There is no difference in the opinion of the diagnosis. Okay. It's a frankly gallbladder.
Yeah.
South we see a difference.
Yeah. So I was just talking to Vamshi and he told me almost the same thing as Shekhar sir said, that it's far more periams and cholangios than
so
GB.
Again, I think for my practice it's slightly different because we are a referral center for cholangios and periams. So probably that's one reason why we get more. Yeah. We have to analyze our data.
So this is very surprising to me, because I see 80-20. 80% or even more is gallbladder. The others are much smaller numbers. So I think geographically we are divided that way. Yes, possibly. I agree. Completely agree. Yeah, I agree with that. There is a geography thing and we have a referral bias as well, as you're saying. Yeah. One last question. Do you treat your non-metastatic patients in terms of locally advanced cancers differently from frankly metastatic patients? Any one of you?
I can just answer for in our practice. See, thought is when it is a locally advanced, you cannot operate. The surgeons do keep sending us for saying NACT, but frankly, the responses are not great in gallbladder. Okay. The number of patients we can transform into an operable is probably 10-20%, not more than that. That's our experience.
So if the patient is younger or fit patient, then I try to give these patients the 3 drugs combination by adding the nab-paclitaxel and with some hope that it will become the operable. So that's the thing I try to do in the non-metastatic disease.
Dr. Akshay?
Sometimes we add RT also if
that's what I was trying to get at, is do we at all consider radiotherapy in this, because it's a less studied modality, but occasionally you can, when you're not sure. So this is our first case. You can go through it. It's a 56-year-old lady who's presented with history of GB calculi and then found to have a GB mass. So I'll read it out, so no problem. Is GB wall thickening predominantly in the fundus and body. There's GB calculi, limited liver infiltration, some enlarged lymph nodes, no METs. No IHBRD, liver otherwise is clear. Chest X-ray, CT thorax is normal. You did a tumor board and the tumor is resectable. So my first question is something that Vamshi alluded to. Would you ever consider neoadjuvant therapy in such a patient? Dr. Priyanka, maybe?
No, I will agree with my surgeon and go for surgery.
Okay. Leave this patient aside. Do you ever consider any patient of GBC for neoadjuvant therapy? Is there any criteria that you use in clinical practice or in your institution?
So again, if it is very close to the confluence, that margin might be a challenge. So that's where we are being asked to give neoadjuvant, but honestly, like I said, not many of them get converted. Okay. If it's a frank obstructive, then mostly we don't take it. We take it as a inoperable.
So largely neoadjuvant as a concept not happening, not convinced.
Not happening for gallbladder.
That's what I can get. Fair enough. Okay. This is just, please. Okay. Yeah. So this is, yes, sir, please. So would you agree with these criteria? I was just hoping for a surgeon around, so I got one. So this is the criteria that we use. Not all of them you have to agree with, but what I want to convey is that not all patients clearly fall into well-defined categories. There are those patients where you don't want to call them, palliative upfront. There is a gray zone there. This is the criteria that we use, and this is something like what Dr. Ankur was saying, that, if you have OJ at presentation, but no metastatic disease post-drainage, or you have, pyloroduodenal infiltration or something, you won't operate those patients up front. But can you consider them later? That's the point, sir. So please go ahead.
Actually, I was trying to tell this when you were discussing that whether you give neoadjuvant to your patients or not. Ask me, I try and see to it that this group of patients I would not like to take upfront, even though I feel technically. So a lot of those points you have mentioned. And only after that, because gallbladder, as you know, that surgeons are never happy because of the kind of outcome that we have. So all these things, and if I see the tumor marker coming down significantly or this kind of thing, response comes up, then only I'll take up these patients. Otherwise, I'll not take up these patients.
Fair enough.
Anand, can I ask you in your TMH, I mean, if that data you analyze, how many you have given with of this and how many actually went for a surgery?
So this is the 470 patient data meta-analysis, of which 170 were ours. Our study was included in this. It's almost the same. Only 35 to 40% actually undergo resection. And I think that is what most others see as well. But what I'm saying is it's a gray zone where you're in doubt, no harm starting chemo and then taking it from there. That's the point I wanted to convey. Please. I'd mentioned that specifically. After a biopsy. Always. Yeah. Not really. I think that's now a concept that most people are comfortable in, that a USG guided biopsy is fine before starting treatment.
I mean, depends on the center. So we do a lot of US guided because that facility is there. So, it gets done automatically and comes to us. But from our side, it really doesn't matter. Fair enough. Exactly.
I mean, the whole concept of seedling, I think, is now off the table. That's, yeah. He would go for resection up front. I don't think.
Where we are
I mean, we are talking of a question in a question, so that's not something where we should go to, because this itself is just criteria we are using. It doesn't mean that everyone has to use it. It's not even validated. It's just what we are using because we see that number. Yes,
Can
sir.
I answer this shading question?
Yeah.
So this was the biggest the problem area for our ethical approval when we did the study of gallbladder. So we said that we will do the GB biopsies, and everybody challenged this concept. This is around 2018 की बात कर रहा हूँ मैं. उसके पहले कभी सुना नहीं था biopsies होती है, 1 or 2 odd. Everybody used to do FNACs.
Yeah.
So tumor seeding is a real problem. Everybody knows. But when we did this, and there were no much of understanding whether it is happening or not. But everywhere we are comfortable. This our sonologist or CT, the radiologist was comfortable, and we were expecting that some bleeding will happen, some problems will come. But in our study, out of 50 patients, those who underwent surgery, only 2 patients had tumor seeding in the at the site of the
I mean, I think that would be a reflection of disease itself and not necessarily the biopsy itself. We've done, I don't know how many, more than 1,000, and that question does not arise. So I think yes, sir. Yeah. I'm sorry, sir, I didn't get you. Yes. Or you're saying upfront resection? We don't have a comparator like that. I got what you're saying, sir. We don't have a comparator. No, no, 35 gross, 474, 474. Yeah. And 35. So that's a pretty high R0. I got what you're saying, so we don't have that. We don't have that. Yeah, yeah.
Anant, are you doing laparoscopic staging in such situations?
Some of them have undergone. I don't know the numbers in the studies. I'm not sure. I don't know the
So
numbers.
there's very nice work from MAMC Delhi. There is a 400 cases study, beautifully done.
Yes. Yeah.
All
yeah.
such cases were studied, and in that they did the laparoscopic staging, and in that also 35, I think 30% of the patients were metastatic on.
Yes.
laparoscopy.
Yeah. So moving on, for the purposes of discussion, this patient underwent a radical chole, and the final stage was a 3B. It was T2B N1, all margins negative. So I'll start with Sir, Somani sir, or Shekhar Patil sir. Just assuming that you did not give this patient adjuvant, it is a stage 3B cancer, what would you expect the overall survival to be in months, median OS?
Around 12 to 18 months.
Yeah. Any other opinions on that? Yeah. So, I mean, what I wanted to say was
the PFS is more important to talk here.
Also
the
true.
recurrence-free survival is more
also true.
important.
I agree.
Yeah,
So,
overall
what I wanted to
survival-
show is that from stage 2 to stage 3, the survivals precipitously drop. You know, from 70 to 80 months, it goes to 18 to 24. So, stage 3 of GB is almost like pancreas. You know, survivals are not great. It's not like colon or breast or some other tumors. Okay, so for the purposes of discussion, patient was seen in the tumor board, and we planned for adjuvant. Shekhar Patil sir, what would be your treatment of choice?
I'll go for an adjuvant chemotherapy.
Which one, sir?
Jump cisplatin
Okay.
is what I would prefer.
So
if
I've
the
put-
general condition is good.
Yes, sir. Patient is fit
Good.
for all treatments. Okay.
I would prefer general.
Okay. I've put 5-6 other options here. Anyone else?
Routinely, we are doing Gemox right now.
Okay. Okay. Dr. Priyanka?
Cisplatin gemcitabine.
Single agent capacitor.
Okay. Anyone else? Yeah, Ankur?
I'd like to have a detailed pathology report. I want PNIs, I want LVI, I want the number of node margins. So
And,
somehow there will be a tendency to incorporate radiation if we can.
Okay.
On the basis of that ACO trial which came in 2013, that what were the indications of adjuvant radiation in a hepatobilin. So
Okay.
I would
Fair
like
enough.
to have a detailed histopathology
Okay.
report.
For discussion's sake, PNI and LVI is negative.
PNI, LVI negative and nodal status,
1 out of 11 nodes.
adjuvant chemotherapy.
Okay.
If you say me heavy burden lymph node with a PNI, a bit of off-track extracapsular extension or a margin.
I'm not sure they report ECCE much in GB,
they
but
don't-
okay,
they don't,
fair
but
enough.
PNI, LVI and a heavy node.
Yeah, that I agree.
I
So-
mean, I'm just curious because those are the indications where systemic therapy works better. I mean, those are precisely where we would add a chemo rather than add radiation. So,
Fine, but I mean, I agree with him that you need all these factors. I thought there was no surgeon on board, so I got away with this, but yeah. Okay, so 4 of the people here said gem-based treatment. We don't have any phase 3 evidence for it. So why are you doing it?
Basically, with our previous experience of a good response in metastatic disease, we saw good responses,
Yeah.
reasonably well tolerated combination. If the patient's general condition is good, we feel that
Okay.
that could be the way. But even though
Yeah.
we know that we don't have evidence
Yeah.
to support it.
There's actually a very small South Korean study which came only this year, and they actually said it didn't improve some survival compared to capecitabine alone. But I agree with you, so we do gemcitabine cisplatin, we would not move away from it. Gemox, I'm surprised because there's a negative trial. So that is something I would not consider. But yeah, this is the available modern day studies. I have not shown any studies before 2014. Yes, sir.
So it's basically the extrapolation of the data from the metastatic
yeah.
disease. And the capecitabine is also one of the valid options if the general condition not so good, especially in the earlier stage of the disease where you think that the borderline indication for the adjuvant treatment is there. You may give the capecitabine also.
I completely agree. And we should remember that almost all these studies have only 20% of gallbladder. So when we have done a trial in TMH, we don't know what to use as the baseline only for our assessments because we didn't have any GBC adjuvant data. And now we are finding out that a lot of this data is iffy when it comes to GB. This is just a couple of meta-analysis in the current era. What they say is that gem-based should not be used, and if at all you're using, use adjuvant chemo radiation. But I think this is a work in progress, and within 4 or 5 years we'll have more info. This is a study we have done. We have now completed accrual in Tata, where we have looked at gemcitabine cisplatin versus capecitabine and K-party. We'll assess results probably in March, April. And this is solely to get an idea of what happens to GB. We don't even know what we are going to get. It is definitely not what is available in the trials, that much I can tell you. There are far more recurrences even in 1 year, for sure. So, but yeah, this is something that we can look forward to from India next year. This is the second patient. It's a patient who had presented with obstructive jaundice. A CT and blood work was done suggestive of obstructive jaundice, and there was frank metastatic disease. Patient underwent drainage, bilirubin reduced, and so this was a question that I asked in a meeting 3-4 weeks back as well. What is the bilirubin level that you're comfortable starting chemotherapy with, Dr. Akshay? 5. Vamshi?
So we look at reduction at least below 5 minimum.
Oh.
Again, look at the trend. If it was 15 and it's come down to 6, I may be tempted to start it if otherwise fit.
Okay.
Something like that.
Sir? 5. Okay, so I think 5, less than 5 is what they're saying. We are comfortable with less than 3, but it's individual call. I agree. Do you use chemotherapy in patients with PS2? Technically underrepresented. Do you use chemo in patients with PS2? If you do, what? I mean, what regimen?
I start with single agent gemcitabine, and then once PS improves, then double.
Logical say, I mean, that's what all of us, I think, do in clinical practice as well, that either that or maybe reduce doses of both drugs and see how it goes. Fair enough. Yes, sir?
Have the temptation or the reason to use in the PS2, I think Folfox is better tolerated than any other regime.
Yes, I agree. Maybe tolerance. Gemcitabine based largely at reduced doses or alone also is reasonably tolerated, but I agree with you. I mean, Folfox is a long use regimen, we could consider it, yes. This was a moderately differentiated adenocarcinoma. Would you consider any biomarkers? And I'll start from the left. Somani, sir?
So yes,
and I've given you a list of 10.
Yeah.
So
I would like to do the NGS panel, basically to see the MSI or MMR, HER, FGFR, or the real like NTRK or IDH and this all. And we know that currently druggable are something like HER or MSI. TMB, yes, it is being prescribed in the literature. You may get the report. And PDL1, I don't pay much attention as on today.
Great to hear, sir, because that is a very confusing one, the PDL1. I don't know what to do with it when patients come with their reports. Anyone else with a different opinion?
You asked me today what is the data available and what I can use in India. I'm happy to do only HER2 and MSI and leave it at that.
Yeah.
Most of the patients who can afford do go for an NGS, mostly because of pressures here and there. PDL1 patients are asking us, I don't see the value of doing it.
Completely agree. Completely agree.
I ask you, the affordability is not a problem. So would you like to do a broad panel or you would like to do the limited available panel? Because tomorrow you may have the actionable mutation, drug for the mutation which you are going to do today.
That's why I said, sir, given a choice, I wouldn't do it because I don't find any such mutations. But affordable and 10 opinions, we do and send an NGS. I don't find anything useful so
available evidence says that actionable targets are yet to be found in GB at least. More cholangio, yes, I completely take your point. But yes, if logistics and finance is not an issue, you could do it.
Even if you find mutation, are they actionable also? We don't
Yes, sir, exactly. Exactly. So, we did a HER2 and it was 3+. Vamshi, would you use a HER2 targeted therapy? Okay. Yeah. Anyone else would use something else? HER2 positive gallbladder cancer. Anyone else? Any experience? I know Amol sir gives, even lapatinib for a lot of patients, and he has published some preliminary work on that. on HER2 cancers. But I think most of us, I mean, lack of evidence, yes, but we would consider trastuzumab. It's not been evaluated in the first line yet. We'll have data from India next year, hopefully. But yeah, I mean, that's something we could consider. So this patient, assume that the same patient was HER2 negative, proficient MMR. Then what would you do? And I'll start from the left. Somani sir.
Sorry, can you repeat it? I mean,
The same patient, now, HER2 negative, proficient MMR.
okay.
And has some constraints for therapy.
And the bilirubin still remains the
Now
high.
normal, now
Okay.
normalized.
So if I find the patient suitable, then maybe that doublet chemotherapy, obviously I would like
Gem
to
and
go.
cisplatin.
Gem platinum or maybe the Folfox. If still I am doubtful about the performance status of the patient.
Okay. PS1.
So I would like to go the standard of the care, that is a gem plus cisplatin.
Anyone who would consider something else?
So as I said in the beginning, that the NAP paclitaxel for certain patient, if young and fit, but not for the patient who had obstructive jaundice, even if the jaundice is relieved,
Okay.
I don't find them suitable.
Okay, from a fitness point of view, you're not convinced. Any experience with any of the other regimens other than Gem-Cis? Gemcitabine, oxaliplatin, anyone? No? Okay. Because Atul Sharma says phase 3 study is there, and that's from India where they were almost equivalent. So that's another option that we can use.
Based on that only we are using Gemox, and tolerance wise it's quite okay. So
I think, yeah, I agree with you. We occasionally use Gemox and it seems okay. The other ones, Gem-Cis, Napacli, as sir was saying, there's very nice response rates, almost double a doublet, and the survival is also around 18-19 months, but ongoing phase 3. Sure. Yes? We use 1,025. I mean, 1,000 of gemcitabine and 25. Yeah. Oh, okay. Some people use 75 day 1. That's what you're referring. Yeah. For a long while, we've used what the ABC 2 guys had used, 25 and 1,000, and that seems to be well tolerated.
Yes. So
Okay.
comparatively, Gemox, Gemcis, when we divide the cisplatin, it is more comfortable for the patients actually.
Okay. So I agree. Atul Sharma sir is very comfortable with it. He uses a 3-weekly regimen, by the way. We use a 2-weekly one, but I agree that it's very well tolerated. Fair enough. Anyone for maintenance? I've given a patient Gem-Cis. I've given it for 8 cycles, 6 months over. Patient has good quality of life. Disease is controlled. What next? Anyone?
So it depends on the how much is the patient, what is performance status and what is tolerability.
PS1, no chemo-related toxicities or largely no chemo-related toxicities,
So
doing well.
So I used to stop platinum and continue gemcitabine.
Okay. Anyone else?
I have tried oral metronomic with the celecoxib. I have tried gemcitabine 2 weekly. I have tried capstabine also in 1 or 2 patients. Nothing really works. 3-4 months later they relapse. I mean, that's my experience.
Okay.
Again, others
So you think 6 months is kind of a barrier beyond which things are iffy. That's what you're saying.
So 4 to 6 months chemo, after that maintenance, within 3, usually the next scan they progress.
Okay.
There's one patient who has done for around 5 months on gemcitabine 2 weekly,
Okay.
3 weekly gemcitabine.
I think all of us have formed our own way of treating these patients. Some people use gemcitabine bi-weekly. I do that a lot. Some people shift to capecitabine because it's oral. There's actually very limited evidence. There is no prospective data for this at all. So I think it's based on disease burden, fitness, quality of life. I agree. This is our trial where we are looking at a maintenance regimen of bevacizumab and erlotinib after 6 months of chemo. Hopefully that might give us some answers in the coming future. So the same patient now suddenly becomes affordable, and this was discussed in detail by Amol sir on immuno. I won't go into the details, but I think what he said on the biomarkers, I think is very true. I think the best biomarker is just MSI. All the others are iffy, to say the least. PDL1, I don't know what to do with it. TMB, I don't know what to do with it. And thankfully, a lot of people don't know what to do with it. So I think MSI is the best marker and nothing beyond that. And this was, of course, discussed in detail. I think we've run out of time, so I'd like to thank my panelists and thank you for the audience. Thank you.
Thank you, Dr.